You have directly an underbite. Okay? And another one is when you have a class 3, okay, wherein when the patient closed, it causes an interference and then it shifted the jaw forward. Then you get now a pseudo class 3. Okay? So when we have this type of a malocclusion, a class 3 malocclusion, one option that we can do, okay, is probably we can do extraction of the lower first premolar, retract the canine, do anterior retraction, then you will be able to correct the underbite of the patient. Okay? Or you can probably do a class 3 elastics, being a long class 3 elastic. Okay? So when you have, okay, when you wanted, okay, to use a class 3 elastic, your main purpose is to move the mandible backwards. Okay? Not just the teeth, but you wanted the jaw to go backward or rotate it backward. Okay? So one of the side effects of a long class 3 is that where it is attached, there will be extrusion effect. Okay? So if you attach it from the upper first molar to the lower canine, then you get an extrusion of your upper molar and also an extrusion of your lower canine. Okay? So that is one of the side effects. And it can, okay, also rotate, okay, the mandible backward, but there will be a little bit of an extrusion. So here is a case of an 18-year-old female. Okay? If you look at the mandible, it is a little bit very protruded, okay, more forward than the maxilla. So intraorally, you get diastema on the mandible, okay, and the mandible is a little bit shifted to the left side. Okay. That's why it resulted to a crossbite also on this particular area because of the shifting. So there is a midline deviation of 3.5 millimeter going to the left side, and you have an underbite of 5.5 millimeters. So on the right side, okay, you have a full class 3 canine molar relationship. On the left side, the molars are class 3, but the canine is class 1. So this is the occlusal view. You get a very wide mandible arch, okay, and a little bit ovoid shape on the upper. Okay, that's why it has a lot of diastema on the lower. So the diastema can give us an advantage when we are doing class 3 cases because it can help us do a little bit of a retraction. Okay, then you don't need to make the movement of the mandible more backward because you already reduced the underbite of the patient. Cephalometric would show you, okay, a very flat occlusal plane. Okay, the teeth on the upper and also on the lower are very flared. You get an open bite because it's 53, okay, and it's 101, which is a skeletal class 3 pattern. So this is the panoramic view. Okay. So after level alignment, we right away proceed to the MEAW wire, okay, and we started to close all the diastema. That's why the underbite started to reduce. Okay. So we asked the patient to wear a short class 3 elastics, okay, which is from the upper second loop to the lower first loop on both the right and the left side. Okay. So even if here it's almost class 1, we still could ask the patient to use the class 3 vector elastic. Okay. So we just use the power chain to close the diastema on the lower, which can help us reduce the underbite. So this is the occlusal view. So you can move your class 3 vector either from the second to the first loop or the third to the first loop. Okay. We seldom would move all the way to the back, okay, to the 4th or the 5th loop, okay, because doing that, it will extrude your posterior segment, okay. And our activation is to do tip back to intrude, okay. So if you have the elastics go all the way to the molar, then it defeats the purpose of you doing intrusion on your molar area. That's why we only stay until the 3rd loop. So after that, you'll be able to see, okay, canines are now in class 1 on this side, but now it becomes class 2 because we use the class 3 vector. Okay? So now we have the positive overjet. So we just continue, okay, until we will be able to improve now the bite of the patient or the occlusion of the patient. Okay. And once we are in good canine class 1 molar, okay, then we change now to an ideal wire, okay, and before we would remove now the braces. Okay. So this is the occlusal view and the profile of the patient. So if you try to compare the before and the after, you were able to move the mandible a little bit backward, okay, by rotating it and correcting the midline. Okay, although there's a slight midline deviation, okay, you can still move probably, but it will become more class 2 now on this side. Okay, so that's why we removed it already. So I also have another patient, okay. This particular patient is a very special patient because she is we call it an OFW. She worked outside of the Philippines and she just come to the Philippines for a certain number of weeks and then go back again to her work in London. Okay, so when she came, okay, she wanted to have her teeth corrected. So in reality, she's a Bimax class 3 type of an occlusion. Okay. Intraorally, if you look, she has a very thick underbite, okay, crowding on the anterior, upper, and lower teeth. Okay. She has a missing premolars already. It was previously extracted, maybe because of the dental caries. That's why they removed it. Okay. Not because of orthodontic treatment, but because of caries, dental caries. Occlusal view, okay, you can see now the crowding on the anterior region. Okay, she has all the way until the third molars. Third molars are present on the upper, okay, and on the lower, okay, the third molar is present, also erupted. Okay. So this is the cephalometric radiograph. Okay. Also very flat occlusal plane, okay, and open bite tendency and class 3 skeletal pattern. So this is the panoramic, okay. She has missing third molars on this side, okay, but the rest of the third molars are present. So our decision is to do level alignment. So when she came, we did the level alignment. After installing the bracket and placing the night-eye wire, she left already. Okay. And then I saw her back again after 6 months. Okay, she came back to the Philippines for a short vacation, and now teeth are fairly aligned. Then I changed now to my MEAW. Then I place all the bends. Okay, and if you try to see, all my I did individual ligation because she will leave again. Okay, to her work. So I just gave her a lot of elastics. Okay, I asked her to wear a short class 3 elastics, okay, and then she left the clinic again, and then I did not see her for quite some time. Okay. Then she came back again after 1 year. Okay, after 1 year she came back again. This is the occlusal view. Okay. So she came back again. The bite is already almost edge to edge. Okay. So I asked her, I activated it again, I do the space closure, okay, and then continue again with the elastic wear. There's still cross bite here, okay, I try to expand the wire only, I did not use any mulligan because I'm afraid that when she leaves and with the mulligan wire there, it might overexpand the arch. So I just need to expand using the wire only so that I can control it because I don't know when she will come back again after the adjustment. So this time, okay, she came, okay, I asked her to wear double elastic. So double elastic meaning class 3 and a class 3 triangle elastic, because this is, she can stay for 2 months, okay, during this time, because it is, she was able to ask for a longer vacation from her work, okay. So I asked her to wear this, okay, and then trying to correct it before she leave for the country. When she came back after a month, okay, I already was able to get into class 1 K9, okay. Of course, the molar will be class 2 because it's a upper second premolar extraction, okay, and then getting into good overjet overbite already. I figure 8 tie, okay, everything, and then because she's going to leave again for the country. So after this adjustment, I never saw the patient again. She did not come back again to the Philippines. So she stayed in London for a long time until now. Okay, so I did not see her. So I was wondering, okay, how her teeth is now. Okay, so I tried to search again the Facebook. Facebook is very good. Okay, especially if you wanted to see lost patients. Okay, that you wanted to reconnect them. Okay, so I tried to search her again, and I messaged her how her teeth are now, okay, and she said that she had her braces removed already when she was in London. So I took a picture of her now, okay, so without her braces, okay, so yeah, she had a good overjet now, she maintained it, okay, but of course I don't know what is happening now because I never saw the patient. Until now, I didn't see her yet, okay? Because she did not go back again, okay, to the Philippines. So how about if you have class 3, okay, that is in the decidus dentition stage? In most of the cases, okay, we can either give patients appliances because decidus teeth, we cannot do anything. We cannot place brackets on the decidus. So you can either give appliances to the patient to be able to improve. Maybe an extraoral appliance or an intraoral appliance. So for this particular case, patient is very young. Okay, she is just 5 years old. Okay, when he came, he has an underbite. Okay, profile is good. Okay, he's not really a class 3 type of a profile. So if you look at the occlusal view, okay, he has a deep bite, class 3, okay, underbite. So this is the occlusal view, okay, with all the decidus teeth present. So for this particular case, okay, we decided to place an overdenture, okay, on the arch, on the lower arch. So we took an impression, okay, we articulate the patient in such a way that we ask the patient to move the mandible, go back, and take the working bite. And from that working bite, we were able to place it in the articulator. Of course, the mandible will be, okay, based on where we want them. Okay? So after carving it, take an impression and pour sulfur acrylic. Okay, then you now have an acrylic. Okay, so unfortunately, because I don't do any general dental work, I only have clear retainer, clear acrylic in my clinic. Okay, so I use the clear acrylic, sulfur acrylic, and then ready for the patient when they come back. So when patient comes back, okay, I install now the denture, okay, the overdenture, and then let the patient go home. So when the patient came back after 2 months, okay, without doing anything, okay, just with the overdenture, okay, you can see now that the mandible moved a little bit backward, and you get now a positive overjet and overbite. Okay. Then after that, okay, and then we remove now the overdenture. So of course you will have now the opening of the pipe because of the position of the acrylic. Okay, so you just leave it like that, and then it will just extrude by itself. Okay, in time. Okay, but as long as you get the anterior segment in good overjet over pipe, then you were able to correct it. Okay. So I think I have very few time left. Okay. I will probably go into open bind. So when we have open bind cases, okay, we normally can classify two kinds of open bind. We have the skeletal open bind and we have the dental open bind. Okay. When we talk about skeletal open bind, we have open bind that started from the first molar all the way to the anterior segment. That is the skeletal open bind. And when we talk about dental open bind, maybe it is just on the anterior to the premolar area that is in open bind, then probably it's just a dental open bind. Okay? So we have many ways of treating open bind. Okay? You, depending on the cause of the open bind, it can be due to a habit. Okay, then you have to give a habit-breaking appliance for that particular patient. Or if it is due to other factors, then you have to consider that. Okay, if it is due to posterior discrepancy, then you correct based on the posterior discrepancy. Okay? So one of the things that we do, okay, for the MEAW mechanics is that from an open bind, we use the MEAW, we do the tip-top bend, and with the elastics, okay, you will be able to close the bind. Okay, so here is a patient, okay, who came, okay. It is a transportation. She was treated by another dentist, and she has a tongue thrusting habit, okay, which resulted to her open bind. So the dentist gave her a appliance, okay, like a crib, okay, tongue crib, to prevent the tongue from moving out, okay, then hoping that the anterior teeth will close by itself. Okay. So this is the intraoral picture, okay, where you have the open bite and you have now the tongue crib, okay, that is installed, okay, by the previous dentist. So the patient has been wearing this particular appliance for more than 1 year, okay, but the open bite did not close. Okay. Originally, it will close by itself if the tongue is the original cause of the open bite. But unfortunately, for this particular patient, it fails to close the bite in spite of the appliance that the patient is wearing. So cephalometric, you can see now, okay, the open bite tendency, okay, with the 64, okay, the patient is a class 1 open bite case. Okay. So this is the panoramic radiograph, okay, with all the teeth that are present, okay, and all the third molars are also present. So when the patient came, okay, our decision is to do the fixed retainer, fixed braces right away. Okay, we remove now the tongue crib, okay, and then we do the level alignment, and then we do the multi-loop XYZ arch. So this is a classic open bite case that is supposed to be treated easily with a multi-loop XYZ arch. Unfortunately, the patient is a non-cooperative patient. So meaning, even if you give elastics to the patient doesn't use the elastics. Okay? So what happened? You will never be able to close the open bite. Okay? It will always stay open. And sometimes it will worsen, it will become more open bite. Okay? So when we install the MEAW wire, we continuously give elastics to the patient, asking the patient to wear the vertical elastics. She's not wearing. She keeps on telling us, yes, she's wearing, okay? But you can see, okay, that she is not wearing it. How? Because when I asked the patient to wear the elastics, she had difficulty placing it unless she look at the mirror. If you are a compliant patient, you can place the elastic without looking at the mirror, okay, if you are a compliant patient. that you regularly wears it. But she cannot. She has to ask for a mirror and she has difficulty placing the elastic. It means that she is lying. Okay? So, but we can only do so much. Okay? And during this time, it just so happened that I was able to learn about the mini implant. Okay? The mini implant from Dr. Park, okay, from Korea. So, when I went back to the Philippines, I was so eager to use the mini implant because I felt that it is a very good tool that can help me in my mechanics. Okay, so when the patient came, okay, I installed now the mini implant, okay, on the posterior area because I wanted to intrude. Okay. So because this is my first mini implant case, okay, I'm so scared of placing implants on the palatal area because of many blood vessels and nerves on the posterior area that I'm still a little bit hesitant to place it. So I just place it on the buccal area. So this is one of my mistakes, okay, when I wanted to intrude my molar and I only place it on the buccal and then my pool is on the buccal. Then what will happen? It will make my molar to tip buccally into a crossbite. Okay? That is my mistake. But I cannot do anything because of my fear to insert mini implant on the palatal region. Okay? So I continue intruding it, okay, with either with a ligature wire or with elastics. Okay? So when the patient came back, it did not close, okay? Because this time the patient is not wearing any elastics, even if you try to ask her to wear, okay? So I'm just relying on my intrusion of my posterior segment with the help of the mini implant, okay? So try to do it, okay? If you try to look at the right side, you can see now my molar getting into a thick overjet, buccal overjet, okay? Because my molar is now starting to tip buccally, because of the direction of the pull on the buccal segment. Patient came back, yeah, the bite closed, but I can see now my molar on the right side getting into a cross bite. Okay? But during this time, I was so happy, okay, because the bite started to close. Okay? So that is my main goal, is to close the bite, and then I will just deal with the cross bite on the molar later, okay, by correcting with the use of the wire. Okay? So it would be better, okay, that you have to place something also on the lingual, okay, to intrude the molar without any side effect on the molar area. Okay? So after that, okay, bite started to close, okay, I just continue, okay, with my activation, okay, on my posterior segment, okay, until, okay, I was able to close now the bite, and then I remove now my MEAW wire, okay, and then I will try now to do the correcting of the interdigitation. So just continue with it, okay? The patient is not wearing any elastics anymore, okay? Although she never wore it beforehand. Okay? So I try to interdigitate on the premolar area, okay? So I place Kobayashi, I asked the patient to wear box. So of course, the patient will not wear the elastic because during the time when I asked her to wear elastic during the MEAW mechanics, she did not wear. What more now will she wear? Okay, so she did not wear the elastic. And then I removed now the braces, okay, with good overbite and overjet. Okay, there is a slight opening on the posterior area, okay, but I will just rely on the normal extrusion of the teeth, okay, to interdigitate. So this is the occlusal view. Okay. And then this is the patient now. Okay, so she's a very beautiful girl. Okay, lady. Okay, profile is very nice. Okay, because we did not do anything, and in the first place, her profile is already good. Okay, before we started it. This is the cephalometric radiograph. Okay. And then this is the panoramic. The third molars are still there. Okay. So then, I searched her again in the Facebook. Okay, she is now there. The bite is still normal. Okay, good bite. Okay, so I don't have any problem with her bite yet. Okay. So one last, okay, is for class 3 open bite. Okay, we know about gum metal wire. Okay. So everybody knows about the nutrients of the gum metal, okay, that they can use it also for correcting, and it is almost like an alternative to the MEAW wire, okay, because the MEAW wire, we have a lot of loops, but this one, okay, we place a little bit of a loop, okay. So this was introduced, okay, and invented by the late Dr. Hasegawa, Shin Hasegawa. So he introduced the gum metal, and he uses the same mechanics as that of the MEAW wire, which is a rowboat effect. Okay? Because for him, he will twist the wire, and then he will upright the molars, and then he will be able to get into a good occlusion on the posterior area. So I tried it on one of my patients. Okay? So this is class 3 open bite case. Okay? The mandible is protruded. Okay? So if you try to look at the intraoral picture, you have an open bite, full class 3, canine molar relationship. Okay. Occlusally, you have all the teeth present until the second molar for the lower. For the upper right side, second molar is still erupting, but the left side is not yet erupted. So this is the cephalometric radiograph. Okay. We have a -4 AMD, okay, which is a very big class 3 skeletal pattern. Okay. Upper incisors are flared radially. Okay. Lower incisors a little bit upright. So this is the panoramic. So we requested the third molars to be removed on the lower. For the upper, the surgeon decided to wait, okay, for the third molar because the surgeon said that it's a little bit too high. They wanted it to go down a little bit before they removed it. But for the lower, they removed the lower. So we did the level alignment, and then we installed the gum metal wire. So this is on the 5th month. If you try to look at the gum metal, there's no loop in it. Okay. But nowadays, okay, if you try to listen to other speakers talking about gum metal treatment, they would place loops, okay, on the canine, distal of the canine area, on the premolar area, okay. But this was taught to me by Dr. Hasegawa that he did not ask to place a loop. We just did a very heavy tip back bend on the premolar molar area, okay, without the vertical loop. Okay. But now we have a lot of speakers who do the vertical loop, okay, which is also good, okay, because it gives you a break on each segment, okay. Unlike if it is a straight wire without loops, then it is a continuous wire. Okay. With a loop, okay, it gives you a break on each segment. So we ask the patient to wear a short elastic, okay, which is from the first premolar all the way to the canine hook on the lower, and then ask the patient to wear the gum metal wire with a very heavy progressive tip back bend. On the 6th month, okay, I feel that it's a little bit slow for me, okay, but I can see that the bite starting to move a little bit into class 1, okay, but the open bite is still present. So on the 8th month, okay, canine molars are almost class 1, okay, open bite is still present, okay. I have some spaces that I am now starting to close with the use of the power chain. And then we ask the patient to wear vertical elastics now, which is from canine to canine. Okay, and then from there, the bite now started to close. Okay, then we remove now the braces. Okay, this is the after 16 months. Okay. So you get now the good overjet overbite, okay, class 1 canine relationship. Molars is class 3, but canine is class 1 and premolar is in good interdigitation. So this is the occlusal view. And the cephalometric radiograph, okay, because we did not do extraction, okay, the incisors are a little bit flared still, but it reduces, okay. So if you try to compare the before and the after, okay, I'm sorry, the picture, the nose was cut, okay. You can see an improvement in the profile of the patient, okay. There's a reduction of the mandible, okay, going backward, okay, good interdigitation on the canine molar relationship. So, okay, so just to summarize, when we are trying to use the multi-loop edgewise arch wire, we have to look into consideration the case selection. Okay? Some would say that I can use the MEAW wire in all my cases. Okay? Yeah, I think you can use the MEAW wire in all your cases. But for me, I would probably select, okay, because MEAW needs a lot of wire bending. Okay? If I can treat that particular case with a traditional straight wire mechanics, then I will do the straight wire mechanics. Okay? I will not go into the MEAW mechanics. And you have to also take into consideration what is the chip complaint of the patient. Because there are certain patients that would say, I wanted you to correct this particular case, but I don't want any extraction. Okay? So if you don't want any extraction, even if it requires you to have extraction, but the patient doesn't want, okay, then we try to think of ways, okay, to veer away from that extraction and try to correct it orthodontically, okay, without doing any extraction. We have to also think of the biomechanics for that particular case. Okay? Am I equipped with enough knowledge to use that particular mechanics, okay, that can help in my treatment? Okay? So, if I'm confident in using it, then you can, okay, use that particular mechanics, okay, and treat it, okay, for the advantage of the patient. And then patient compliance. Okay, you need cooperation of the patient, especially if you are asking the patient to use the multi-loop edgewise arch wire. Okay, if the patient doesn't wear the elastics, then that particular mechanics, no matter how good it is, okay, it will not correct. Okay, just like what you see, okay, on the second to the last case of the open bite, wherein if the open bite doesn't close, okay, because the patient compliance is very poor. So I need the help of another, okay, accessory materials to be able to help me correct that particular malocclusion. And maybe nowadays, a mini implant, okay, is a very good tool, okay, that can help us, okay, in our treatment protocol, okay, in our goals, okay, which can give us a very good mechanics. If we only know how, we know what type of implant to use and where to place it, okay, then you'll be able to use it properly. Okay? So, with that, I would like to thank everyone for the kind attention and for the invitation from OSA.
So,